I am Dr. Anand from ILBS Hospital, second year resident. So my patient is Mrs. XY, 78-year-old female, married, illiterate housewife, resident of Delhi, informant being son, reliability is good. Date of admission is 7th of August 23 and examination was done on the same day. Was presented to emergency in ILBS with complaints of lower limb swelling since 15 days and a decrease in the urine output since 15 days. Patient was with no previous comorbid condition, was apparently alright 15 days back when she noticed swelling which was present in both the lower limbs around the ankle joint, abrupt onset, progressive from ankle to the thighs along with the upper limbs. Swelling was not present over the face and was not associated with any chest pain, palpitations, shortness of breath on exertion, orthopnea, PND, or recurrent episodes of respiratory tract infections in the past. Also, it was not associated with any abdominal pain, yellowish discoloration of the eyes, or the black stools. Swelling was associated with decrease in the urine output. Like that, the son told me she used to go for urination around 6 to 8 times initially, and now the frequency has decreased to around 2 to 3 times over a period of 15 days. And also, there is a decrease in the amount of urine as per the history given. Swelling was associated with a rash which was present over the lower limb, which are multiple small rashes which are red to pink in color lesions over lower limbs and which was not associated with any itching, burning sensations, ulcerations or pain. Patient was also experiencing easy fatigability for last 1 month as patient is not able to do the household work. For all these complaints, patient consulted a local practitioner and who has advised a few investigations and given symptomatic management. Investigation, what he remembered was low hemoglobin, and he was told that there is a leak of blood and the protein in the urine, and the patient BP was told to be normal at that time, and the creatinine was 1.4, and attendants were told to visit a nephrologist and take consultation from them. Patient then subsequently was admitted in one of the hospitals where some IV injections were given, after which there was increase in the urine output and swelling over the limbs decreased. But after 5 days of stay in the hospital, patient took LAMA from the hospital and went to home with the discharge creatinine, what he remembered was 2.1. Patient was also transfused with 1 unit of blood in the hospital in view of low hemoglobin count. In negative history, there was no history of any frothing of urine, passing blood in urine, noxuria, burning micturations, any graveluria or cola colored urine. There was no history of any hemoptysis, arthralgia, oral ulcers, hair loss or photosensitivity. No history of any back pain, backache, fractures or bony pains. No history of any headache or blurring of the visions, and no history of any fever, cold, cough, vomiting, loose motions, skin infections, ear, nose discharge, and no toothache. Patient, when had gone to the home, was symptomatically better at home for next 1 week when she again developed swelling and decrease in the urine output and shortness of breath, and now again admitted in some other hospital where they were told about the deranged kidney function, and the reports of creatinine was in the range of 6.9, and along with this there was increased TLC count and was started on IV antibiotics. Patient was also given 1 sessions of hemodialysis, which what he remembered was given through the neckline. Some catheter was inserted and it was given in view of fluid overload and raising creatinine levels. And routine investigations are sent along with few investigations as per the attendant like ANA and
अब
ANC.
यहीं पे वो investigation I don't want. ठीक? So some investigations were done. Otherwise there is no charm in the case.
Okay.
So I have told you कि you stop at the history. So anything else you want to tell about the history?
Sir, when apart from the swelling and the decrease in the output, patient was experiencing the easy fatigability and excessive
नहीं ठीक है वो हो गया. Don't repeat the same things. So anything else you want to say, or it is all over because you were going on the test, so I purposely told you not to go further. What we are discussing then? We are discussing a bedside. So want you all to know how would you approach this case? This is not a case presentation which you are doing. No slides are required. You have to have your papers and you just write the history. Exam you will not be supposed to present on the slides. Okay. Any other information without any investigation you want to add, or everything is done? Okay. So now you just give me a brief of the summary and what is your clinical diagnosis when you saw the patient first in the ward. Okay. So what are the salient points in the history and what is your clinical diagnosis?
So elderly woman presented in emergency ILBS uh, with complaints of swelling over the limbs and the decrease in the urine output, along with the easy fatigability and shortness of breath since 15 days. With investigations and medications taken from some other hospitals,
उसकी
where
कोई ज़रूरत नहीं है अब आप पेशेंट की पॉइंट समराइज करिए
with this history and with rise in the creatinine in the higher range, which he remembered, my diagnosis will be whether it can be an acute kidney injury or rapidly progressive renal failure.
Okay. ठीक so this is your so your basic presentation of this patient is abrupt onset of swelling in the lower limbs along with decrease in urine output plus some constitutional features like generalized weakness and there was a rash and बाकी सारी negative history है कि so what would you think of the causes in such a patient 78-year-old woman she comes to you with generalized anasarca and rapidly deteriorating renal function. You have told कि initial creatinine was 1.4, later on 2.1, and now she had creatinine of 6.9 and she had one dialysis before coming to you. So, what are the possibilities?
Sir, in this age old group, if the
And you said no comorbidities. Okay.
with no previous comorbid conditions and with this age group, with this constitutional symptoms along with the this swelling and this decreased urine output, the possibilities of the causes for rapidly progressive renal failure can be taken into account.
Okay. So,
And
one you are thinking renal etiology, and in that you are thinking either AKI or this thing rapidly progressive renal failure. You have already talked about कि there is it doesn't seem to be a cardiac or liver issue.
yes,
ठीक so we are now concentrating otherwise when you come across such a patient you will see कि कोई congestive heart failure तो नहीं कोई chronic liver disease which is decompensated ठीक and so these will be the major cause so now uh, why do you say that what is the difference कि does she have acute kidney injury you have given two diagnoses कि acute renal failure or it could be rapidly progressive what will you like to entertain as first diagnosis
sir, I would like to entertain as a rapidly progressive renal failure, sir,
ठीक
because
so
the
हाँ
duration
बोल
has already become more than around 20 days, sir. So mostly, if the acute kidney injury will be there, then it should have been subsided. And
is
the re
subsided why are you using the word subsided AKI will not subside within 20 days ठीक है it may recover it may not recover and it will may take longer time to recover so don't say this thing कि if it was AKI it would have recovered but AKI because here you are saying कि over a period of 2 weeks his creatinine increased from 1.4 to 6.9 so acute kidney what is the definition of a acute kidney injury
sir, if the rise in creatinine as per KDGO 0.3 milligram per dl within 48 hours is there, or if 1.5 times to 1.9 times baseline rise in creatinine within 7 days, it will be defined as acute kidney injury, sir.
देखो definition is definition these are criteria which you are telling so definition is हाँ बताइए, प्लीज सिलो, within hours to days. So rapid decline, please sit down. Rapid decline in the renal function over period of few hours to few days. ठीक है, with all the consequences of renal malfunctioning. ठीक है, which can be oliguria, anuria, uh, azotemia. So these are, but it is hours to few days. But here you are seeing that it is over a period of rapidly progressive, over a period of 2 to 3 weeks, she has gone on to end stage renal disease. So that is why you call it as a rapidly progressive renal failure. So what under this head, what are your possibilities?
Sir, the first possibility will be rapidly progressive glomerulonephritis can be there, sir.
Okay.
Secondly, autoimmune vasculitis can be considered, sir.
नहीं, वो तो उसी के बीच में आ गई ना. So this is one RPGN. Okay, you want to add कि it is a vasculitis, but that is a part of that disease.
Yes.
So what is one is rapidly progressive glomerulonephritis / vasculitis. Okay.
Second, sir, IgA nephropathy with crescents can be considered.
Okay.
Infection-related glomerulonephritis can be considered, sir. But there is no history of
No,
any.
you are giving all the differential diagnosis of RPGN. I am just asking you what are the other causes of rapidly progressive renal failure.
Sir, it can be
Though it's not a terminology out of your 10 renal syndromes, but rapidly progressive renal failure, it will encounter so many possibilities besides the RPGN. So what are those?
Depending upon the compartment which are involved, sir, either vascular or tubulointerstitial compartments can be there, sir. In vascular, the possibility of thrombotic microangiopathy can be considered.
Okay.
HUS-TTP, malignant hypertension, systemic sclerosis.
Yeah, so these are the things. Ki malignant hypertension, systemic sclerosis with scleroderma crisis, TMA or HUS, ठीक, or anything obstructive uropathy.
Obstructive uropathy, acute tubulointerstitial nephritis can be considered.
Okay, but that will come in acute kidney injury. But in rapidly progressive failure, these are malignant hypertension. And what you can qualify your term as IgA nephropathy with crescent. So it is a transformation of IgA into a crescentic phase. So, but scleroderma crisis, malignant hypertension, postpartum renal failure, that is again, though it is not there, but I am just asking you the causes of rapidly progressive renal failure. So, now, do you think it is a glomerulonephritis or there is no hypertension?
No
Okay.
hypertension.
No skin involvement?
Skin rash.
वो रैश छोड़ स्क्लेरोडर्मा वाली बात, शी इज़ नॉट प्रेग्नेंट. सो अब IgA विद वैस्कुलाइटिस वो हम बाद में देखें. अब सो हाउ डू यू से दैट शी हैज़ गॉट glomerulonephritis? What are the features in this patient?
Sir, but as per the history की
नहीं, अब हिस्ट्री बोल दी, अब आप पॉइंट्स बताने मेरे को कि क्या क्या फीचर्स है.
sir, edema was there, sir.
Yes.
Hematuria. Typical features were.
So why you have yourself said कि urine routine examination, she was told to have proteins and blood in the urine. So you have yourself said in the history, she did not have overt hematuria. You told कि there was no frothuria. So there was decrease in urine output, volume and frequency wise, and one report which you are aware of, there was blood and protein. So what else you require? Okay? So what are the features of a glomerulonephritis? प्लीज बैठ खड़े नहीं होना बैठ यस हाँ हाँ। नहीं वो तो पार्ट ऑफ इमेच्योरिटी तो डिरेंज रीनल फंक्शंस एंड हाइपरटेंशन तो देखो सिंपल कितने एच होते हैं सो हाइपरटेंशन हिमेचूरिया एडिमा एंड एजोटीमिया decrease urine output so these are the feature oliguria may not be present in 100% of cases it is present 45 50% of the cases but hallmark of a glomerulonephritis is hematuria glomerular hematuria there you qualify with that dysmorphic RBC and hypertension and decline in renal function. Okay, so you have all the features. Hematuria, proteinuria, as evidenced by the urine routine examination. There is oliguria, there is edema, ठीक? And you have told कि creatinine baseline 1.4 and there is progressive rise. So now it's clear कि it is a rapidly progressive glomerulonephritis. Now you are saying कि what is the ये red spots? Is it a rash or they are purpura? What it is?
Sir,
Lower limb में तुमने बताया ना कि red spots है.
red spots were there, sir, looking like purpuric lesions.
So how would you differentiate purpura from these purpuric spots?
Sir, as per size also we can differentiate. कि
Yeah,
if it
बताइए points बताइए.
if it is less than 3 mm or more than 3 mm, accordingly if it is less than 3 mm it will be petechia, more than 3 mm will be purpura, whether it is blanchable or non-blanchable.
So blanchable size doesn't matter. ठीक?
Yes.
So blanching, non-blanching. Purpura will be blanching or not?
No, non-blanchable.
Okay. Or
And
size, it can be vary. Site, purpura can be there all over the body.
yes,
But what are the specific sites for a purpuric lesion? Vasculitis lesion.
so mostly on the lower limbs it will be
Lower
present, sir.
limbs and yeah, these forearms.
Forearms.
ठीक है? So there is a specific distribution of vasculitic purpura. Lower limb may be anterior compartment of the lower legs and these forearms
Okay, sir.
and they are palpable, non-pruritic, non-blanching. So these are so that is how you would say that it is a palpable purpura. ठीक है? Petechiae will be all different and they may be purpuric, blanching, size may be from pinpoint to pinhead or millimeters, usually less than 3 millimeters. So that is a difference. So now you are saying कि there is an evidence of glomerulonephritis plus there is a rash.
Right.
Now what are the possibilities which you will
With this, sir, some immune mediated nephritis will be there, sir, with rash and involvement of the kidney, and accordingly we can further go कि whether
नहीं,
it is
अब तो आप बड़ा सिंपल है अब आरपीजीएन पे आ गए सो व्हाट आर द कॉजेस ऑफ आरपीजीएन वी हैव नैरोड डाउन टू दिस डायग्राम क्या आरपीजीएन में क्या क्या पॉसिबिलिटीज हो सकती है वन
Sir.
यू हैव टोल्ड immune complex
so immune complex can be there, autoimmune vasculitis can be there, uncorrelated vasculitis, anti-GBM disease can be there, sir,
ठीक
and infection related glomerulonephritis can be one of the cause, sir. IgA vasculitis, IgA nephropathy with crescents can be considered in
वो
RPGN.
तो फर्दर आए ना व्हाट आर द थ्री बेसिक कॉजेज ऑफ आरपीजीएन immune mediated immune complex posse immune and anti-GBM disease
linear deposition.
वो तो अब आप ये IgA nephropathy, infectious, they come in what head? हाँ जी तरुण बताओ. Yes, so they are under immune complex mediate. उसमें पोस्ट स्ट्रेप्टोकोकल और पोस्ट इन्फेक्शियस GI, IgA. What are the other causes? Even more common causes. Immune complex.
Hypocomplementemic vasculitis can be there.
Which is rather more common. SLE.
SLE, lupus nephritis.
वो तो C3 नेफ्रोपैथी की बात कर रहे हो आप, है ठीक है, पर वो है दैट इज नॉट सो कॉमन, बट दैट कैन हैव ट्रांसफॉर्मेशन इनटू RPGN and there it is immune complex mediated. But the common causes are post-infectious, SLE, IgA nephropathy. ठीक. Any other cause? C3 आपने बताया, cryoglobulinemia. Okay.
Anti-C1q hypocomplementary vasculitis can be there. MPGN pattern of
और
injury.
cryoglobulinemia. बाकी अब ये है कि associated with other primary glomerular disease क्या होती है जी. So membranous with the crescentic transformation. ठीक. और there can be a combination of anti-GBM disease with ANCA positive or ANCA with this ENA positivity. So these are the various possibilities. Ab here, what do you think that in this patient, what could be the possibility?
Sir, ANCA vasculitis is more likely.
So why
sir.
do you say?
Because of the old age, sir.
Yes.
Second is typical rash which was present on the lower limbs and the involvement of the kidney, and with the constitutional symptoms which are present since 1 month, sir.
ठीक है. So considering now coming to ANCA associated vasculitis, so what is the RPGN, what is the usual prevalence of these three diseases? Immune complex, which is the most common cause of ANCA, RPGN?
Immune complex mediated.
But if you look at all ages, so what would be more common? Younger age, middle to older age. What is the Hanji Yogita? So post-immune is always the common. ठीक. Then comes, so percentage wise, can somebody tell?
Sir,
60 to 70% तो बहुत ज़्यादा होता है, पर अराउंड 45% के करीब जो है, if you take all ages, तो then it is this thing post-immune. 25% or so it will be immune complex, and around 10 to 15% it is anti-GBM. But after the age of 50, then it is almost 60 to 70%, and after age of 75 or 80, majority are ANCA associated. Clear?
okay, sir.
So now diagnosis wise, your ये जो है case clinically, if you make a diagnosis from the history, you will approach like that. Now you tell me, how would you investigate this patient?
First of all, I would like to do the complete blood count, kidney function test, liver function test, PTINR, and then urine routine microscopy, urine protein creatinine ratio, 24 hours urinary proteins, in RPGN C3, C4 levels, ANA, C-ANCA, P-ANCA, also anti-GBM titer I will send, and chest X-ray, ECG, 2D echo, and SOS, I will go for renal biopsy.
So actually, otherwise it is very simple कि you will be doing that. ठीक. अब now, what do you expect कि what could be the renal findings if you do a biopsy? अब क्या क्या टेस्ट आपने कराए? चलो अब आप बता दो क्या टेस्ट कराए, बिकॉज यू आर वेरी कीन इन टेलिंग. सो लेट्स सी कि अच्छा उससे पहले आप एग्जामिनेशन बताइए. एग्जामिनेशन में व्हाट डिड यू फाइंड? इसको अभी बंद कर दो. क्लिनिकल एग्जामिनेशन.
Sir,
Because bedside is a how do you approach a case, not you discuss the reports, but we will give you the reports. Okay, so clinical examination.
sir, in clinical examinations, pallor was there, sir. There was icterus sinuses clubbing lymphadenopathy was not there. Edema was there on bilateral lower limbs. Pitting edema was there, sir. And vital wise, sir, BP was around 130/40 and 80 to 89 in diastolic in the right arm supine positions. And pulse and other things were within normal limits, sir. And skin, hairs, nails were normal. Ear, nose, throat, and this tooth were normal. On the skin, that purpuric lesions were present, sir. And in the systemic examinations, severe CN.
What is the difference between history and this thing? Now this rash you are going to ये जो है describe कि what is the kind of rash. अब देखो when you present your clinical findings, you are telling very casually blood pressure 140 to 150 and 80 to 89. Did you check the BP in on various occasions or you saw the patient
Sir,
once?
so patient.
And उस वक्त क्या था? अब एग्जाम में तो 10 बार थोड़ा बीपी चेक करो. तो you have to be very specific कि this is the BP today, this is the weight today, and what is the kind of rash, and ear, nose, throat you are saying normal. What did you see in the ENT examination?
Sir, in nose any nasal crusting was there or not, and ear any discharge was there or not, sir, and throat any congestion or anything was there or not, sir. So nothing was there, sir. And blood pressure which I
Chalo, okay. Now you describe the rash.
it was, sir, purpuric rash, sir, reddish to pink in color on the lower limb, sir, and it was non-blanchable, and no itchings were there, sir, no ulcerations, nodules, or any discharge present from the side, sir.
ठीक. और so besides anemia and rash, is there any other positive finding? And edema?
Edema was there, sir.
Nothing else. Did you examine the nerves, peripheral nerves?
No, sir, peripheral nerves are not.
So why there is a need to examine the nerves? जरूरत है या नहीं?
Yeah, sir, any neuropathy is present or not, sir?
न्यूरोपैथी तो इट्स ए नर्व कंडक्शन एनसीबी डायग्नोसिस. एग्जामिनेशन में तुम न्यूरोपैथी देखोगे? क्या देखोगे? एनीबडी? Have you heard about mononeuritis multiplex? So you will look at the nerves which may be thickened. Ulnar nerves हैं, peroneal है, common peroneal है, which you can feel, and they may be there. Especially the kind of diagnosis you are making. Okay.
Okay, sir.
So there is no positive. Did you examine the urine?
Yes, sir.
Did you examine the urine?
No, I have not myself examined, sir. But
No, you should have examined. कैसे करते हैं examine urine?
sir, we'll take the around 5 to 10 ml of urine in a container, sir. Centrifuge it at around 5 to 10 minutes at 1500 to 2000 RPM.
So
Then,
container कौन सा होता है जो urine के लिए lab वाले
yes, sir,
देते हैं?
tubes, sir. Test
तो
tubes,
फिर
sir.
test tube
Test
बताओ
tubes.
ना.
Test tubes, sir. And the clear supernatant will be thrown out. Then we'll pick the sediments at the lower part with the pipette and we'll keep it on the slide, and then we'll form a smear, and accordingly, depending upon the magnification at 10x or 40x, we'll see about the everything.
So what are you going to see? So सबसे पहले तो ये माइक्रोस्कोपिक से पहले you will look at the proteins. ठीक है. So I'll do a albustics test or yes, albustics and look for the proteins. That will also अगर multisticks है तो that will tell you about the blood also. So protein and blood dipstick test से हो जाएगा. पर चलो okay, I am interested कि so you did not do, but what do you want to see?
We want to see, sir, the about the proteins and the RBCs.
नहीं, अब तुमने वो स्लाइड बना ली, अब स्लाइड में तो आरबीसीज देखोगे या और चीज़ें देखोगे, तो क्या क्या देखोगे?
सर RBC पस सेल्स सर.
तो पस सेल्स नहीं, डब्ल्यूबीसी.
WBC सेल्स.
सो आरबीसीज यहाँ पे कैसे मिले? सो यू विल लुक फॉर कि देर इज माइक्रोस्कोपिक इमेचुरिया, बिकॉज देर इज नो मैक्रोस्कोपिक. You have been told about कि there was blood and so you will look at that.
Yes.
So how do you look for dysmorphic RBC?
Sir, we'll require phase contrast microscopy.
Okay.
Then we'll come to see.
Okay. So what is the definition of dysmorphic RBCs?
Sir, as per quantity wise, if more than 40% of the dysmorphic RBCs are there, it will be mostly of glomerular origin, and the shape and the size of the RBC will be distorted in the dysmorphic RBC.
Is it
The cylinder-
40% or something else? क्या? So 40%. मेरे ख्याल तो ज़्यादा है, but if you are saying so dysmorphic, so they are why they become dysmorphic?
Sir, basically, whenever the origin of this RBC is from the glomerulus, they will go and they will combine with the TAM host protein which is present in the DCT, which is a hyaline cast. And this combination of this hyaline cast and will
कास्ट की बात कर रहा हूँ, हम तो अभी शेप की बात कर रहे हैं. So when they pass through the tubules, they change their shape. So that is one of the thing कि it is a glomerular hematuria. But what is the hallmark of glomerulonephritis?
Yes, RBC cast.
Yes. So RBC cast. That is the hallmark of ठीक. और now you just tell me कि what are the investigations? So you have told all. So you have told what is the platelet count?
Platelet count, sir, was 150 to 160.
So there was no thrombocytopenia.
No thrombocytopenia.
So
sir.
rash was not because of purpura.
Yes, sir.
ठीक है, hemoglobin was low.
Low, sir.
Okay. So what about his immunological parameters?
This
ANCA.
ANA was negative, sir. C ANCA was positive. P ANCA was negative, sir.
Okay.
Then we did the PR3, that was positive in 776 range, sir. Highly positive, and MPO was negative.
What is C ANCA or so now what do you call C ANCA, P ANCA or something else?
MP3 and PR3 and MPO.
PR3.
Proteinase 3 and
So
myeloperoxidase.
PR3 is what?
Proteinase 3, sir. C ANCA. C ANCA.
So
MPO
that
is
is GPA associated is
GPS.
PR3.
Yes.
And microscopic pan,
Pollen, that is
which
MPO.
you, so that is a MPO.
MPOs.
Because now there is a pathological definition also. PR3 positive, MPO positive or no positive, which is ANCA negative vasculitis.
Yes.
Okay.
Yes.
So are you aware about classification of vasculitis?
Yes, sir. There are two classifications, sir. As per histology, Babden classifications, whether the 50% of the glomeruli are normal, then it is focal. If it is more than 50% crescent present, then crescentic nephritis. If more,
मैं तो vasculitis की बात कर रहा हूँ. So vasculitis है?
Chapel.
So क्या होती है chapel? Okay, these are basically large vessel, medium vessels and small
Small
vessels.
vessels.
So अब large vessel में क्या आता है?
So giant cell arteritis and Takayasu arteritis.
So Takayasu arteritis, फिर giant cell, और इसमें medium size.
Polyarteritis nodosa and Kawasaki mucocutaneous lymph node syndrome.
Now this is.
Small vessel vasculitis.
तो ये चैपल इन क्लासिफिकेशन कैसे आई है? लॉर्ड चैपल और समथिंग एल्स? हाँ, एनीबडी? तो चैपल ने डिस्क्राइब किए. सो दैट इज ए प्लेस. चैपल हिल इज ए, और वो कॉन्फ्रेंस दैट इज सेंटर फॉर रूमेटोलॉजिकल डिजीजेस. So okay, so this is the classification of that, because your treatment depends upon your etiologies. So that is a basic classification. So now he is PR3 ANCA positive.
Yes.
ठीक? But it is only limited to kidney, no ENT involved.
No.
Okay. ठीक. So did you do the biopsy?
Yes, sir. We somehow did the biopsy around 3 days back, sir. But reports
Okay.
are still awaited, sir.
The report is, but what do you expect?
Sir, necrotizing crescentic glomerulitis may be present, sir, in view of ANCA positivity. What we have discussed provisionally, sir, they told us this.
नहीं, अब क्या देखते हो तुम? ये what do you expect with this kind of your reports, renal functions and all that? तो इसमें क्या 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 देखोगे? बायोप्सी तो बाद में आती है, आप एक्सपेक्ट करते नहीं यार मैं आई एम गोइंग टू सी दीज थिंग्स. ठीक, सो यू आर गोइंग टू सी द क्रिसेंट्स.
Crescent, sir.
ठीक है, आप क्रिसेंट्स जो है कितने परसेंट देखोगे, सोचते हो कितने परसेंट होंगे? सो व्हेन डू यू कॉल इट इज क्रिसेंटिक ग्लोमेरुलोनेफ्राइटिस? कितने परसेंट होने चाहिए
More than
ग्लोमेरुलो?
50%.
So to have a label of crescentic, it has to be more than 50. But some people even less than 50 they call it, but it should be more than 50% to qualify for the definition of crescentic. तो अब इसमें क्या expect करते हैं?
Sir, because of this rapidity of the presentation, mostly crescentic nephritis will be there.
नहीं,
sir.
वो तो है 50% से तो ऊपर होंगे, it may be more.
No, sir.
And now you were telling कि sclerotic or mixed or whatever.
Focal.
So यहाँ पे क्या expect करते हो? How old is this disease?
It's just, sir, 28 days,
So,
less than 1 month, sir.
so what do you expect?
So,
Cellular crescents or
cellular crescent, sir.
there can be some sclerosis or fibrocellular also.
Yes.
क्योंकि देखो now there is chronicity unless कि you have treated this patient and it might change little bit of histology. ठीक है, क्योंकि I would expect कि patient will be having more of a active lesions, but some amount of out of 20 glomeruli 16 are showing cellular crescents, 2 or 3 are partially fibrocellular. तो इस तरह की पिक्चर आपको देखेगी. So anybody, why crescentic glomerulonephritis occurs? So what is the pathogenesis? आप कहाँ से हो यार? आप क्या नाम है आपका? हैं? कहाँ से हो आप? हैं? अपोलो से. तो बताइए. ये क्रिसेंट कहाँ होता है? एंडोथेलियम में होता है. Outside where? You're right. Where? So Bowman's capsule. So it again depends upon the severity of glomerular injury. So glomerular capillary, there is inflammation, and sometimes inflammation is very severe कि there are pores or rents in the endothelium, and what in ये leaks into the Bowman space. What are the things?
Neutrophils.
So they get a leak into the, and then they there is leakage of neutrophils, monocytes, ये जो है TNF alpha interleukins, and there is formation of proliferation of the cells, and that is how the thing. What are the good prognostic features? ठीक? You can have good prognostic features in this thing. What are those?
So, in
Histologically.
if it is focal, sir.
So focal
Focal.
crescent, segmental crescent.
Segmental crescents.
What is the difference between focal and segmental? Focal क्या होता है?
Less than 50% of the glomeruli are involved, then it is focal. And in a single glomeruli, if it is just a segmental involvement, then it is segmental.
So segment is a part of that
glomerulus.
Focus, some of the glomeruli are showing these changes. ठीक है? और diffuse is when most of the. तो इसलिए you should understand कि what is the difference between segment. It is only a segment of the glomerulus. So if there is focal proliferative glomerulonephritis, if segmental less than मतलब 50% पर it will not qualify for that definition, but जितना कम है crescents 50-60% है और एक कोई 80% है, तो दोनों में प्रोग्नोसिस में फर्क पड़ेगा. बट इट इज़ द एज ऑफ क्रिसेंट्स कि इफ दे आर सेलुलर then it is a good prognostic feature. Okay, so this is the pathogenesis of the crescent. So now how would you treat? Okay, this patient now you have investigated, you are awaiting a biopsy, but this patient is there with you for last almost 10 days.
Yes, sir.
So how have you managed this patient?
Sir, when the patient...
Or how would you manage? Because I will not ask how, I'm not going to comment on anything. But how would you manage this patient?
Sir, if it is a diagnosed case of
नहीं, if it is क्या, अब तो आप इसकी if but की है ही नहीं.
Yes, sir. We go with the induction and the maintenance regimen, sir. And we'll start with the pulse steroid, sir. 500 milligram per day for 3 days, followed by the 1 milligram per kg of the steroid, and we'll taper.
So 100 milligram per day or something else? You are saying 100 milligram per day for 3 days.
Pulse steroid for 3 days.
So pulse is 100 milligram or something different?
So 500 mg, sir. I told 500 mg, sir.
Oh, I heard 100. So okay. So 500 milligram pulse for 3 days.
3 days.
Okay. What is the weight of this patient?
Weight is 55 kg, sir.
Okay.
Followed by 1 milligram per kg of the oral steroid dose, sir. And we'll with the rapid tapering and the low dose steroids should be preferred, sir.
So rapid tapering कैसे करते हैं?
Sir, they halve the dose at the end of 1 month, and according to the weight, sir. If the weight is less than 50 or 50 to 75, so in my case, it should be started at 60 milligram. Then half the dose should be done at the end of 1 month, that is 30 milligram, and at the end of 4 months it should be around 5 mg. Then this 5 mg should be given.
What regimen you are saying? कौन सी guidelines?
This is for that per sir Paxivas trial, sir.
But guidelines. So it is around 6 months. By 6 months you stop it, and agreed कि 4 months you reduce it to 5 milligram. Okay. So this is one thing is your pulse steroids followed by 3 doses of pulse followed by 1 milligram per kg and this tapering. So that is one.
Yes, sir. Along with this, I will go ahead with IV cyclophosphamide at the rate of 15 milligram per kg, sir. For the 3 doses, it should be given at the interval of 2 weeks, sir. Then accordingly, at the interval of 3 weeks, sir. 7, 10, 13, and 19, 20, 24, sir. Total of around 10 grams of cyclophosphamide should be given over a period of 24 weeks, sir. So this steroids with cyclophosphamide for severe
ये कौन
diseases.
सा regimen है?
So, KD goes, sir.
KD. So anybody differing with him? नहीं चलो मैं तो ये अभी डोज पे बात कर रहे हैं, आप साइक्लोप्स की बात छोड़ो, वो तो बाद में करेंगे, वहां पे पहुंचेंगे. अगर एक चार हैं 1 age factor. So it is not a book पढ़ ली कि भी 15 मिलीग्राम पर केजी पर ये जो है पर डोज 50 ये एवरी 15 days into 2 or 3 doses and then 3 weekly for 3 to 4 months. Not
As
अब
per sir
इसमें
age will
यार
reduce.
बेटा this is your 78-year-old patient.
Yes.
अगर आप 15 मिलीग्राम इसको दोगे मार दोगे उसको. आपको तो दो तरह से इसकी रिडक्शन करनी है, बताओ बेटा. अगर इसके क्रिएटिनिन 2 होती, जैसे उस वक्त आया है आपके पास तो क्या 6.9 पे आया है, पर सपोज इसकी क्रिएटिनिन 2 होती, व्हाट डोज वुड यू हैव गिव? So after the age of 60 you give 2.5 milligram lesser and after 70 another 2.5. तो इसकी डोज आपकी 10 milligram per kg बनेगी for by the age criteria and by criteria of creatinine इसकी डोज तो और बहुत कम हो जाएगी. तो ये देखिए you have to look at the patient's age, renal functions. For his creatinine, I think 7.5 milligram per kg dose will be enough for her. क्योंकि that मतलब at the time which she is coming to you. ठीक है?
Yes.
So there are modifications according to age as well as the creatinine. And what about steroids also? Suppose ये जो steroids you have told correctly, but cyclophosphamide, so you are going to give her IV cyclophosphamide.
Yes, sir.
Have you given that way or
Sir, actually we won't be able to give sir IV cyclophosphamide.
you have not given?
Not given, sir.
ठीक है. But you wanted to give in this dose,
Yes, sir.
for bedside. अच्छा और क्या करना चाहोगे इसको?
और सर प्लाज्मा फेरेसिस के लिए.
Plasmapheresis. Okay. Why?
मतलब सर creatinine was as per criteria in KD goes. If it is more than 3.5 we can go ahead with plasma pheresis, sir.
But what are the latest ये जो recommendations or what is
So,
the latest thought
so
about
long
plasmapheresis?
term mortality is not affected in the 1 year if we go ahead with plasma pheresis also as per the Paxivas trial, sir. Just we get the time for the dialysis session, sir. The rapid deterioration in the GFR will be little bit, we'll get time for HD sessions, but long term mortality has no benefits.
So okay. So you are saying that there is a severe organ dysfunction, that is why you want to give plasmapheresis.
Yes.
That is the only, if you go by that criteria. Otherwise, patient does not have any hemorrhage or neuritis. Because what are the indications for a plasmapheresis? बताइए.
Sir, if a diffuse alveolar hemorrhage is there, sir,
Okay.
and if it is a double positivity, sir, ANCA and anti-GBM both are
good.
positive, and anti-GBM positive, sir,
Okay.
then these are the three
So
conditions.
अब तो हम पर डबल पॉजिटिविटी यहाँ पे आ जाएगा कि डबल पॉजिटिविटी है और दूसरा एल्वियोलर हेमरेज है, एनीथिंग एल्स? अभी मैंने बोल ही दिया, ऑप्टिक न्यूराइटिस है किसी
ऑप्टिक
को,
न्यूराइटिस
ठीक है, और एक्सोप्थेल्मोस हो रहा है, या कई बार इन लोगों को ये जो है कार्डियक ये कॉर्नरी वेस्कुलाइटिस है. So those are the indications for this thing, and here just because patient has got rapidly rising creatinine, कोई फायदा नहीं, ठीक है, you are wasting of the reserves, there is no, and that you have already told. So what you have said ki long term, at least 1 year they did not find one any decrease in incidence of end stage renal disease or mortality. पर क्या चीज़ ज़्यादा थी, हैं?
साइड इफेक्ट्स
Side effects. But
Prone for infections.
so infection.
infections
So infection related mortality was more. So actually पैक्सीवास का जो मैसेज है वो यही है कि लॉन्ग टर्म में कोई फायदा नहीं हुआ, ठीक है. सो दैट इज व्हाई योर इंडिकेशंस फॉर प्लाज्माफेरेसिस शुड बी दोस. यू आर गिविंग वन शॉट, मतलब सॉफ्ट इंडिकेशन की जी बड़ा फास्ट बढ़ रहा है. आई थिंक इट रिक्वायर्स द अर्ली ट्रीटमेंट, डोंट कीप ऑन वेटिंग. सो जो सेकेंड हॉस्पिटल वेयर शी वेंट वाज कि she had come to you at that time, she would not have reached the stage of 6.9 grade.
Okay, sir.
ठीक.
Okay, sir.
So uh, you will be giving her steroids, pulse, oral steroids. Ab now why your teachers, why your seniors have not given cyclophosphamide?
Sir, the main thing ki when the patient has presented to us, there was a very high TLC count, sir.
So this is what. So you had told ki there was a raised TLC and she had fever.
Fever was
So, अच्छा, okay. But
fever was
I
not.
think कि TLC was raised.
TLC was very high, sir.
हाँ, तो फिर so you have to, now you have already told कि इसको TLC high था, लिखा हुआ मैंने.
Yes.
तो you say कि भाई ये जो है presently I will not give cyclophosphamide because patient had ये जो है high TLC, but once condition allows, I might go for that with modified doses according to her age and create. ठीक है. अब यहाँ पे एक पॉइंट तुम्हारा बनता है कि इफ अ पेशेंट हैज सेप्सिस and you are not able to give cyclophosphamide or something else, I'll come to you कि what other drug in ये induction. तो वहाँ पे एक अल्टरनेटिव है आपके पास प्लाज्मा फेरेसिस. कि प्लाज्मा फेरेसिस इज ए सेफ चॉइस इफ you are having rapidly progressive renal failure and you are thinking a patient is in sepsis, this will be safe. So that is an indication. Okay.
Okay, sir.
So now her counts have settled.
Counts have settled, sir. Just 2 days
Okay.
back, her counts are in normal.
So
range,
would
sir.
you like to give her pulse IV cyclophosphamide or
So I will try to.
oral cyclophosphamide?
Sir, as TLC is decreasing, then again we will become suspicious whether we should go
तो
ahead with
अभी
our
अभी you should be conservative.
Yes.
ठीक है. पर ये है कि लेटर ऑन थोड़ा सेप्सिस ठीक हो जाता है, यू हैव टू गिव, यू हैव टू बी बिट एग्रेसिव, पर यू हैव टू कंसिडर हर एज, risk of infection. She is already infected. So disease will not kill her, you will kill her by giving immunosuppression.
Yes.
So that you will have to see. Okay.
Yes.
But theoretically, what is the difference between IV cyclophosphamide and oral cyclophosphamide? हाँ.
So So relapse rates.
So पहले कौन सा ट्रायल था ये? हम्म, नहीं अब ये जो आईवी वर्सेस जो ओरल है ये किस में देखा उन्होंने? साइक्लोप्स में?
Yes, yes.
व्हाट इज रिटुक्सीवास?
Steroid and cyclophosphamide with rituximab.
जो साइक्लोप्स बताओ क्या था वो? साइक्लोप्स ट्रायल क्या? So outcome was similar, but toxicity was higher, like leukopenia and risk of gonadal or infertility. But with IV cyclophosphamide, more chances of relapse. Right? So Paxi was we have discussed, or what other trials you know of? Have you heard about RAVE? Yogita, bolo. So, what are the other induction agents for yes, ANCA-associated respiratory? So, rituximab. So, RAVE was with rituximab. ठीक? So, where would you prefer RAVE?
So,
Rituximab.
so rituximab should be preferred in the this if the extremes of age are there, sir, and if the patient is in the young age group, fertility issues are there, sir, and if this cyclophosphamide, if we give access availability is not there, then we should go ahead with rituximab, sir. And also in the cases of relapse, this and PR3 positive rituximab should be given, sir. The better alternative.
So, these are the advantages. कि older people and younger people, especially less than 30, you are to avoid gonadal toxicity. So, RAVE, this rituximab is a preferred, and as GPA, PR3 positive, again rituximab is better. Those who have a relapse while on cyclophosphamide, rituximab is better. So, what is the regimen of rituximab?
Sir, there are two regimens are there, sir. One is 375 milligram per meter square weekly should be given, sir. 4 doses or 1 gram at 0 dose and after 2 weeks. Sir.
Okay. So, this is for induction.
Induction regimens.
Okay. And when would you give maintenance?
Sir, maintenance there are in that also there are two regimens. At the completion of the remission after induction, it can be given at 6, 12 and 18 months, and in few studies 4, 8, 12, 16. Sir.
Uh, so, suppose patient has achieved remission after 3 months of induction therapy. So, would you like to wait, or you will still wait, as you are saying, 6 months, 12 months, 18 months?
Sir, now there's a new trial, sir. Main reason 2 has come, sir. So in which if depending upon the CD19 levels, we can go ahead with the rituximab, sir. So that side effects.
But that is why you give it after 6 months, because effect, because you have given it in the first month, and why you are waiting for the for another 5 months, because the effect on the B cell, it lasts has a long lasting effect. तो यूजुअली 6 महीने रहना चाहिए. बट इफ़ यू हैव फैसिलिटीज़ फॉर CD1920, वी आर डूइंग that counts, and then you can see ki whether person requires early, or even I wait for 8 months also. So but you are right ki by doing CD1920 you can see, but recommendation in that trials are ki you give it after 6 months. But suppose you have given cyclophosphamide, then when would you start the maintenance therapy?
So mostly after 6 months.
Why? 6 months पे तो उसको रिलैप्स हो जाएगा भैया. इफ ओरल स्टेरॉइड्स हैं तो इमीडिएटली ये ओरल साइक्लोफॉस्फाइड दिया तो यू चेंज इट ओवर टू ये जो है सेफर वन. ठीक है, एजाथाइप्रिन. क्योंकि अदरवाइज इफ यू वेट फॉर 6 मंथ, दैट इज द क्वेश्चन कि rituximab, if it was given as induction agent, you wait for that. But if you are giving oral cyclophosphamide, जैसे पेशेंट की रिमिशन होती है एंड यू वांट टू स्विच ओवर टू अ सेफर ड्रग, और यू स्विच ओवर. बट आईवी साइक्लोफॉस्फेट जहाँ दिया है, यू जस्ट सी कि आपका टीएलसी एएनसी कितना आ गया है. सो डिपेंडिंग अपॉन दैट यू माइट हैव टू वेट फॉर 2 to 4 weeks, क्योंकि आईवी साइक्लोफॉस्फेट का इफेक्ट उतनी देर रहता है. ठीक है. ओके. और क्या पूछे आप तो बता. ठीक. यू हैव डन वेल थ्योरेटिकली, यू हैव प्रेजेंटेड ए गुड हिस्ट्री. एग्जामिनेशन खैर मैंने भी नहीं तुमसे आई वांटेड टू स्किप, पर व्हेन यू आर टोल्ड टू present the examination, you have to tell it properly, not casually.
Yes.
So there you went casual. Otherwise, ठीक है, yeah, you have understood the thing, and you have defended it well. ठीक है. तो अब बता, अब तू इस पेशेंट को कैसे ट्रीट किया है तूने. ठीक.
Yes, sir.
So you have given steroids, पल्स स्टेरॉइड्स दिए.
Bulk steroids दिए सर.
और अभी ये जो है 1 मिलीग्राम पर किलो पे है
40 मिलीग्राम, 40
या
मिलीग्राम थोड़ा कम दे रहे हैं. 40 मिलीग्राम दे रहे हैं सर.
क्यों थ्योरी एंड प्रैक्टिकल इज वेरी डिफरेंट. दैट इज व्हाई आई एम सेइंग कि थ्योरी में तो आप साइक्लोफॉस्फेट दे रहे थे और अभी मैं नहीं दूंगा. अभी डोज भी आई थिंक कि 40 इज फाइन. अब क्रिएटिनिन कम होना शुरू हुआ.
क्रिएटिनिन कम होना चालू.
कितना हो गया
अभी सर? लास्ट जो क्रिएटिनिन 2.2 है सर. इन बिटवीन सर
कुछ इसका फीवर और इन्फेक्शन की वजह से भी बड़ा.
यस सर. एंड यूरिन आउटपुट आना भी चालू हो गया सर. अराउंड 800 ml आ रहा है.
अच्छा. एंड शी इज ऑफ डायलिसिस नाउ.
सर वाज गिवन 4 days बैक सर. लास्ट डायलिसिस वाज गिवन 4 days बैक.
और ये जो क्रिएटिनिन 2.2 है, ये कब की है?
ये सर कल का ही है सर.
कल का. थोड़ा सा डायलिसिस इफेक्ट भी है, पर ठीक है. चलो ओके. और कुछ आप लोग पूछते अच्छा यू वांटेड कि आई वांट टू क्लियर सम डाउट्स.
Yes sir, actually the same doubts are get cleared between this lecture sir, because chest x-ray was suggestive of patchy.
दिखाओ दिखाओ.
Initial x-ray first day sir. So this is the just day before yesterday x-ray sir.
दिस वन डे बिफोर यस्टरडे. और ये इनिशियल
x-ray sir. And
तो
this
नहीं, अब बताओ क्या, व्हाट डू यू थिंक?
so this entire right sided sir patchy consolidations were there sir. Few signs of maybe fluid overload will also be there.
देयर इज ए ये जो फ्लूइड ओवरलोड भी है थोड़ा पार्ट, बट देयर आर इनफिल्ट्रेट्स. ठीक है. एल्वियोलर भी है, पैची नोडुलर इनफिल्ट्रेट्स भी है, मोर ऑन द राइट साइड, लेस ऑन द लेफ्ट साइड. तो बाकी ठीक है. एज कोई पुरानी इसको कोई कॉक्स वगैरह की तो
No
नहीं
sir, no
फीचर्स.
history of COX, nothing is there sir. And this HRCT भी जो हमने किया था सर, तो bilateral multiple centrilobular nodules with areas of colas consolidations, the ground glass capacities in both the lungs, mainly upper lobes, likely infective etiology. Then we went ahead with bronchoscopy sir. Then bronchoscopy में galactomannan was 1.67 sir. So
क्या है आपकी वैल्यू वहाँ पे नॉर्मल?
sir, point
कितना है रेंज? सो इट वाज पॉजिटिव.
positive sir,
ओके.
positive. So started on antifungal sir. So she responded to this higher antibiotics and antifungals. Then we somehow able to do the renal biopsy sir, and then now planning to do this immunosuppressions and everything sir.
ठीक है. सो वन थिंग यू हैव टोल्ड कि दैट इज व्हाई एक्सरे वाज सजेस्टिव कि इन्फेक्शन बैक्टीरिया एंड you have told कि galactomannan positive, but I would like कि what was the fungus culture तुमने awaited है,
अभी awaited
but have you on KOH staining have you got something, because you have done a bronchoscopy lavage, because galactomannan is not sine qua non with the aspergillus infection. ठीक. Have you demonstrated the fungus?
sir. No sir, no fungal elements are there sir.
फिर क्योंकि if you have the sputum you can say the negative है, but it can might be positive, but if you have done bronchoscopy and bronchoalveolar lavage तो you should get it. तो मैं मतलब इसको this is an oversight. ठीक. और आगे
सर ये बायोप्सी प्रोविजनल व्हाट आई हैव डिस्कस सर.
ठीक.
बाकी तो दिस सेम थिंग सर.
ठीक.
Just this course in